This is a lecture for Adler Graduate School, course number 504, Abnormal Psychology. I'm going to define and explain the transdiagnostic approach to treatment, discuss three transdiagnostic processes that are very common, and present a model that elaborates the concept of maintenance factors, placing them into a developmental context. The place of diagnosis in mental health has always been controversial. Many clinicians are uncomfortable with the medical model, which is implied by the diagnostic process. Some prefer treating the whole person rather than a symptom or a cluster of symptoms. Others are uncomfortable with the labeling process that is implied when a person is given a diagnosis. The goal of the DSM approach to human suffering is to create reliable categories of symptoms. This means that there would be a high likelihood that two different clinicians examining the same client would identify the same diagnosis. Reliable classification is essential in research. If a diagnosis cannot be assigned with a high level of reliability, then research on that diagnosis is difficult to generalize. It's difficult to say who the research would be applicable to. For example, if you have learned an empirically supported treatment for people with depression, the research was most likely done with people who satisfied the diagnostic criteria for depression, probably from DSM-4. People with depression and an anxiety disorder were most likely excluded from that study. So it is unclear if the treatment is empirically supported for treating people with comorbid disorders. But the disorder-specific approach hypothesizes that the key onset and/or maintenance processes are significantly different across disorders and that different treatment interventions may be necessary for different disorders. Classification sets a foundation for future developments in science. However, the history of science tells us that classification only takes a field of study so far, and then it is necessary to study universal principles, processes, and concepts. The transdiagnostic approach is an attempt to identify processes which underlie human distress. For example, in individual psychology, all neurosis is thought to be rooted in process of overcoming felt inferiorities. Symptoms are seen as various forms of compensation for the underlying inferiority feelings. In the acceptance and commitment therapy model, mindfulness is a universal healing process for human distress. In a cognitive behavioral conceptualization, thinking errors, or what Adlerians refer to as mistaken beliefs, are universal. The content of the mistaken beliefs differ from one person to another, but human distress is seen as rooted in mistaken beliefs. For example, an expectancy bias, that is, an over-attention to negative stimuli, an overestimation of the likelihood of negative events, and a catastrophizing of the meaning of negative events, is found in both anxiety and depression. Barlow and his colleagues have proposed a unified treatment protocol with 10 components, which they feel is appropriate for people with a wide range of diagnoses. This is something of a shotgun approach to treatment planning, and I'm sure that different clients benefit from different units. They present it as a psychoeducational group and have a client manual. I suppose it could be very useful as an initial treatment in a situation where there were a large number of clients. Dudley, Kukin, and Podesky define case conceptualization as a collaborative effort of the therapist and the client to describe and explain the issues a client presents, with treatment planning based on the conceptualization. In their model, When there is a clear match between the client's presenting issue and a known, empirically supported treatment model, that treatment is used. This is most likely to be the case when the client satisfies the diagnostic criteria for a single disorder. Treatment planning for disorders where there is a limited evidence base for treatment, or for two or more presenting disorders, is more complex and relies more on the case conceptualization and the wishes and priorities of the client. Transdiagnostic processes can guide the clinician to a treatment approach in these more complex cases. For example, in many cases of mixed anxiety and depression, the transdiagnostic process of perfectionism is recognized by both client and therapist as a unifying process underlying the client's presenting issues. Treating the perfectionism is clearly indicated. I find that an interest in transdiagnostic processes helps me stay focused on the client's issues and concerns instead of on their symptoms. In contrast to the disorder-specific approach, the transdiagnostic approach hypothesizes that there is a range of cognitive and/or behavioral maintenance processes shared across the psychological disorders. That is, processes that are elevated in a wide range of psychological disorders that causally contribute to the development and/or the maintenance of symptoms. A number of transdiagnostic processes have been proposed and researched, and I am going to briefly describe the three that I have found most useful in my clinical practice. The first is perfectionism. The defining characteristics of perfectionism are deriving a great deal of personal worth from achievement, and a resetting of the goal or standard higher if it is achieved. The core belief seems to be, I am never good enough. This is a very common cognitive process amongst students. Catastrophic worry is a process of identifying horrendous but highly unlikely possible outcomes for an activity or an endeavor, and then acting as if it were likely to occur. The worrying person seems to believe that all outcomes are equally likely to occur, or that preparing for the worst possible outcome somehow creates safety. Finally, repetitive negative thinking, also known as rumination, is a pattern of responding to distress in which the person passively and perseveratively thinks about his or her upsetting symptoms and the causes and consequences of those symptoms. For each of these processes, there is a questionnaire measure and an emerging body of research on treatment processes. We have discussed perpetuating or maintenance factors in previous lectures. This conceptual diagram from the literature on insomnia proposes a developmental process for these factors. Starting on the left at the preclinical stage, it is assumed that each of us has some predisposing level of susceptibility to insomnia. Onset of insomnia in this model is precipitated by a variety of psychosocial stressors. Over time, the impact of these precipitating factors declines and the person returns to their preclinical level of sleep, unless they begin engaging in the perpetuating factors for poor sleep. For example, after a night or two of bad sleep, the person may begin going to bed earlier or sleeping in later as a way to make up for their lost sleep. The problem is, these behaviors disrupt healthy functioning in sleep. The circadian clock is weakened and the sleep homeostat is unprimed. Our body can only make up a limited amount of lost sleep from the previous night, and then the time in bed becomes disruptive to the quality of sleep obtained and to the next night of sleep.